Okay, we're gonna have call to order regular meeting of the Healthcare District Board. We have Ken's here, Sherry's here, Shelley's here. Rich, are you on the line?
He's muted.
Rich, can you hear us? Well, we'll get back to Rich, and I am here, so let's go ahead and do the pledge of allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you.
I'm here.
There you go.
All right, so next we have additions, modifications, and deletions from the agenda. I have none, anyone else? Okay, with that, we move to item number 3, approval of the agenda. If you please have a motion to approve the agenda.
A motion to approve.
Thank you, thank you. All in favor, Rich?
Aye.
Aye. Sherry?
Aye.
Ken?
Aye.
And I'll vote aye. And that moves us to public comment. We didn't receive any public comment in advance of the meeting. Anyone here have anything they want to say? No? Okay, I just wanted to, remind anyone who is available or wants to go that Dr. Walls' celebration of life is on Sunday. So if you need the details, then, let us know about it. It's posted at the post office and the grocery store, so. Okay, that moves us into item number 5. The approval for the June 23rd, 2025 special board finance committee meeting minutes. So, Shirley, this would just be you and Rich to approve these. So I don't know if you guys have a chance to look at them, if you have any comments, questions on them.
I don't have any questions. I've looked at it. Rich, do you?
No. Good.
So then I guess Rachel will second it.
Second.
Okay, and approve? Okay, all right. That moves us to item number 6, request for approval of the June 26, 2025 regular board meeting minutes. Board members have a chance to review, comments, motion to approve.
Move approval.
Thank you. Second. All in favor, Ken?
Aye.
Sherry? Aye. Shelley?
Aye.
Rich?
Aye.
I'll vote aye. So that brings us to item number 7, the SHE staff and foundation reports. And I just wanted to make a comment before we go into these that I greatly appreciate all the detail that you guys all put in these. It was very, very helpful for me and very useful. So I just want to say thank you for that. And with that, Sean, is there anything specifically that you want to highlight?
No, I think just in general, the board is probably very aware that there's just a lot of legislative things going on, but we'll go to the one big beautiful bill issues and things to that effect, but California is also stacking the deck, as it relates to a lot of legislation that they're trying to push through for healthcare. A lot of you can see through my report, there's a lot of, we oppose a lot of this through our advocacy groups. There's just a lot of stuff that's getting stacked on. It just feels like administrative burden, stacking stuff on, creating liability for the organizations, healthcare organizations in general. I just wanted you to read these and be aware of a lot of them, and I'll take any questions you have. I'm following and tracking these. There's just some stuff in here that's just really icky. It's just not good, and the only one that I support obviously is the extension of the Medi-Cal program, right? Because it's ending. I think that'll probably get pushed through to the 29th, but again, it'll get pushed through in California, but I do want to take us to the last page, which is the one big beautiful bill, and that is, regardless of what California does in Medi-Cal, requires an incredible amount of federal funding through Medicaid. And if you've been listening to any news or you read anything, the rhetoric has not stopped between the Trump administration and Gavin Newsom and the governor of California. It has not stopped. So where this is going, we're still kind of rolling our eyes and trying to figure it out. This has been modeled by many people. In fact, I know Brady and Steve are going to a very focused board meeting around DHLF to talk about how this is being modeled, what the impacts could look like. Steve's doing a really good job. I included a link to an article in here that talks about resilience in the healthcare industry and things to that effect. I think the one thing that we're really going to hold our breath on is reconciliation bills that go through to. I think they've gone so far that they're going to try to create some reconciliation bills and try to save and things like that. No one really knows what that looks like. But it's being counterbalanced by the hawks, if you will, these fiscal hawks in the legislature that want to push it even further. You know, they want to go even further, the specificity of which no one really knows. Because it's a haircut for everybody. Brady, you want to bring anything up on this? Because we're monitoring this on a regular basis.
Yeah.
This is constant.
Yeah, I think, as we go forward and listen to the news and all of that stuff, and we get closer to the elections again, you'll have the positioning, everybody passed that bill. Now there's the positioning of it. So, and this is kind of somewhat in the similar, when the Affordable Care kind of rolled in.
Before.
Yeah,
Yeah,
right before
Yeah.
managed care.
that they did.
Yeah, cause I worked in case management,
Yeah, that they
case
did.
management. Oh, it's terrible, the bad debt.
They didn't really study what effects that would have on the healthcare system, they just kind of.
Yeah.
did it.
Yeah.
And that was part of my dissertation to see what kind of effects it did occur. So the first couple of years, it actually was okay, and then what happened was, then it started hurting the facilities, so. I think, as we get closer to the end of the year, we're gonna have more clarity of what kind of impacts. Now, in this, just like Steve is positioning the hospital in that budget is being conservative, but also going after the revenue side, meaning we have good foundations of, some things we can control, and we need to hit our marks this year, and then that way it pushes against the headwinds that we have, so.
Yeah, there wasn't any exclusion, I didn't see any delineation for larger hospitals versus rural healthcare hospitals at all.
Yeah.
Which was a little scary,
Yeah,
a lot
Well,
scary,
the CHIP
actually.
program is being, levied against CHIP, which is how the Enloe places they make their money.
Yeah,
It's being slaughtered. And then
disproportionate share.
sequestration's at 4%, in the
Yeah.
big beautiful bill stuff too. So there's a lot of not good stuff in there. Overall, I want to bring your attention back to. I think that they're looking for the political reward system through the Trump administration, but they're gonna have to clean this up.
They can-
Because there's a lot of people that are gonna be trying to run with this in their pocket if they can't do reconciliation and figure this out. I just saw an article today. It's called The Help, and it's supposed to rescue critical access in rural hospitals, and they're already starting to position themselves for this. I think the interesting thing is AB 1312 on top of, hey, this is what just chaps me. So we've got the one big beautiful bill, and what they're doing is they're putting the onus for presumptive determination of patients that walk in on us.
It's insane.
Instead of the state taking it on and being able to look at enrollment in these, now they're starting to put it on us, which is just kind of typical, unfortunately. It's like, we don't want to deal with it, we don't want it on our record, so we're gonna make it the hospital's responsibility to do this. And so it's the hot potato, and it's
But
getting
yeah,
passed,
they're not requiring,
not,
you can't require the process.
Correct.
the process.
but this is a huge administrative burden for us. It would be very big to have to do this, but again, it's very typical fashion. Let's get it off my plate and put it on someone else's that's already trying to struggle with figuring out what the haircut's gonna look like as it relates to our reimbursement structure. So stay tuned, folks. It's gonna be a really interesting fall.
So Sean, for that second one, AB 849.
Yeah.
Why do we oppose that one?
Just because they're just being overburdened. So this is a way this was introduced, they want chaperones where they normally don't need chaperones. It could be, literally, it could be a female gynecologist with a female patient, and they still want a chaperone in there. We already do a lot of this.
Yeah, right.
But now
that's
it's
what I figured. That's why-
More bodies in the room, you have to do it more and more. It's just, once again, it's the burden of us having to supply a staff member for things that normally you wouldn't. It just pushes the envelope even further out there for chaperoning.
For the behavioral health, have we heard anything
Wow.
from the county?
Yeah, we just got something, from Miss McGill. She wants to have a conversation,
Ms.
what was it?
McGill's our local.
yeah. And if you look at this thing, they have been thrown money. They're just,
It's just
It's
so.
Sorry.
And I talked to, director over in Boston County, and she told me that the challenge is not the money at all. it's recruiting staff.
Yeah.
And I get that. She said everybody wants to, they get their degrees, their credentials, sign up with locums. So they can't get any local qualified staff.
Well, I will tell you that we have an issue with behavioral health. I mean, the safety net is failing. Emergency rooms cannot absorb it. It's not being managed well, and they're just in typical fashion, rather than going to root cause analysis of what's going on, they're throwing money at it, which they've done now twice. Tons of money in behavioral health, and the results are the same. Once again, it comes down to staffing, it comes down to ability to place. There's not enough places to put people. There's not enough intervention in drug addiction, which is a precursor or an aftermath of behavioral health problems. So we're not dealing with it. We're throwing money at it with no, what I can see, a discernible plan.
I was wondering, is some of this perhaps stemming from the huge increase in autism and spectrum disorders?
Yeah, I mean, and
I don't know, because I was.
maybe it's
doing
red
research
dye
on that.
32,
It's huge.
whatever it is, you know.
Placement is just, there's just no place to put them.
The challenge in rural areas also is having outposts in these remote communities.
Yeah,
You can't find anybody to do the work. To get some really loud voices out there.
yeah.
Yeah. It's something we're gonna be dealing with for a while, and I personally, I think that, great, we have money to do it. What's the plan? What?
But the county is starting to look at it though. Sounds like.
They are, they just wanna talk to us about how it's going.
Staffing and housing are gonna be
Yeah,
the key issues, and housing's a mess for everyone.
yeah, it is, so anyway, very focused on legislation right now, very focused on the OBBA. I know Steve and we're all watching this very closely, as this could be it's one of those transitional things like managed care, the Affordable Care Act, the Affordable Care Act, and then now this. So,
John, for rural communities, I think one of the things that maybe Sherry can chime in on this, is if, you know, you're hiring a bunch of mental health providers as county employees, and you want to pay them more to attract more, then you pretty soon have child welfare saying the same thing, and everybody across
their hand up.
Yeah, with comparable, trying to keep comparable across the department.
And so, you know, it makes a really difficult situation. You can't make any exceptions in that area.
Yeah.
When you guys meet with them, be sure to remember that the whole idea of setting up what is now called the Wellness Center
Mhm.
was to have a place to provide those types of services at a local level. And my observation is over the last 2 years especially, they've been slowly changing their
Yeah.
personnel, changing their programs and becoming less and less available to the people who need it. the
Yeah.
most.
The line, staffing it. It's just not staffed, and they
That's
used
the
to have,
problem. They can't.
once a week, they would have a behavioral health specialist come up from the county and be there for, I think, half a day or something on Thursday, but that's it. That's it. Otherwise, they're just more or less support for people that are, you know, that are in need. They're doing a lot of support stuff, but there's not a lot of behavioral health discussion. And we're gonna continue to talk to Jessica and the team down at the county. But we have not, and I'm talking not just us, the Plymouth District and Eastern Plymouth, we've not been able to really find our pace with county behavioral health. Just, you know, it becomes finger pointing at one point, and then we're like, okay, stop the finger pointing, let's see if we can solution it. And then it's, the solution is always you, and I'm gonna point the finger at us, need to do more. Well, we're not the ones getting all the money.
Yeah.
Yeah, you're getting the money, why don't you do more? Well,
Or
we
they
can't
could-
hire, well, neither can we.
Yeah, they could set up a program where we can provide service, but they pay us to do it. with the
Well,
money.
that was discussed at one point, so it's a little bit of a conundrum, and it's kind of who, you know, who has the money and who's willing to do the work,
Is
and
there an established model that we can look at that's working anywhere in the state?
the
That's-
Sacramento,
Can you try that?
actually. Sacramento, all of the hospitals down in Sacramento came together and literally built inpatient and outpatient facilities that could offload from their ER. So they literally worked with behavioral health down there. This is actually a decent model.
That works for.
Salon has
It's very urban, though,
Yeah.
very urban.
That's a good one.
Solano has a model.
Solana,
Yeah,
Yeah.
I think there's a
yeah, they
few.
do inpatient, outpatient services, I used to work with them,
Um,
but they're so challenged with
trying to think
staffing.
of other ones, that
the
my,
same.
my information's a little dated now, I'm trying to think ones that are traditionally, you know, a lot of ones on the Bay Area Peninsula have some good stuff going
Yeah.
on. San Mateo County has a good model.
Highly funded, but urban, more urban, where, you know, it's just different up here. It's just different. So-
Is there a crisis center in Quincy?
Yeah.
Mental
Yeah,
health
there
crisis,
is, absolutely.
and it's functioning, there is staff,
Fully staffed.
Fully staffed, and not only that, but then Plymouth Rural Services also has a myriad of programs.
so do we send patients from our ER to crisis?
If they don't, so we have telepsych. So, and there's a lot of criteria around telepsych.
Right.
If a patient comes in altered, we can't do an analysis about evaluation, we clear them medically. But they've got to get to a certain point where they can talk to an online counselor. The counselor determines the course of action. So we stop at the medical side, we turn it over. That has gotten better, is that correct? We're able to get a little bit better response. Now, through the telemedicine, the new system. And they determine whether it's gonna be an inpatient, they need to be transferred to an inpatient, or they set them up and try to arrange some outpatient activities for them, but it's hit and miss, like
Are they
everything else.
timely about getting people out of the ER and getting them to wherever they need to go?
I don't have Judy here, but, I don't think so. I don't, we sit on quite a few, don't we?
Yeah, but that service that.
It's been better with the telehealth,
Yeah,
though.
it's been
Yeah.
better than prior to.
We can usually get a professional at least to.
There's always been a bed shortage issue. Getting people out of the ER.
Yeah, and an ER with 2 rooms and 1 nurse and 1 tech.
Work on that.
Yeah, there is. It's a constantly evolving thing. I just hope that it,
Back to the BABA thing, do you, or not BABA, but OBA or whatever.
BBA.
OBA. Yeah,
one big beautiful bill.
do you think that, some of these, I anticipate, or the scary cuts they're talking about with this, are because of AI, the implementation of AI?
They talk about AI, but AI hasn't proven, there's no case studies that's proven that AI is going to replace the clinical side of the business. I
Oh,
mean,
that's robot.
well, I love the little R2D2s that run around. But there's some digital agents that are being deployed to assist with some of the patient access and the billing, stuff like that. But remember, anytime that it's touching a patient and it's considered a medical device of they have to have FDA approval. So if it's a medical device, if it's considered a medical device, which really aids in the ability that when you're touching patients, it has to go through the FDA as a medical device. So a lot of these AI companies are using apps in advance. It's not a medical device, it's not a decision-making device, it's a tool, right? I think that AI is too far out there to consider the OBBA as far as cutting costs to healthcare.
Yeah, I think the stance was more terminate to negotiate.
Terminate to negotiate,
Yeah,
seems to be the way it works
Yeah,
in this administration, terminate to
Yeah,
negotiate.
really, that is.
that's actually a technique.
Well, he uses it obviously with a lot of things, and it works, but there's a lot of pain in between, you know, so. We'll see. We'll see what happens. So that's my report, all government.
Any other questions for Sean on this? No? Thank you, Sean.
Yeah.
All right, so we have Judy's with Philip and Judy.
He is in a very important meeting today,
Like,
partnership.
Speaking of medical.
yeah, and I appreciated her report too, and it was like I did not thought that was pretty funny over that.
Yeah,
And then I gave Brady the stop with lead information, because I saw that they already ordered the kids, but there's possibly other options in the next week.
how are we doing on COVID?
It's rolling around again.
Yeah.
So, so we've had patients and staff over this last probably month and a half. So it's still, it's not a
Weird,
regular
it's sad,
thing,
yeah.
it can be anytime.
Yeah, yeah,
We've had some exposure.
okay. The symptoms aren't severe.
What Judy would say, watching hands.
Yeah, yeah.
I got it. It wasn't fun.
Oh, I'm sorry.
Yeah, it wasn't. We're not getting hospitalizations. How about that?
Good.
Yeah.
Any other questions or comments on the CNO report? Thank you. All right, let's go ahead and move on to Brady. Your report.
Thank you, I'll be real quick. So in the MRI, update. So we did our dry run. Everything Ethan was there and Linda was there, and so we looked good, fire marshal signed off, everything went to CDPH. We're looking at mid-August to start. The team knows that we need 2 weeks ahead of time, once we get the date, so we can start, scheduling patients, so that's looking pretty good, CDPH. Now that it's in that, agency, Linda has relationships to help. Because it was an active service and we had to tell them we didn't have the service. We're looking pretty good for that mid-August, and as soon as we get a date, we'll let everybody know for that. So,
So I think it says, I think in your report said there was a test run.
yeah, we just did the test run, and that's making sure that electronically everything's moving correctly and that the truck driver, some things we found out, he's from this area, so. he knows-
Born at Seneca.
Yeah. From this area, and the MRI tech is in Portola, so they're more local up here, and they know. Yeah, the environment and stuff like that, so that was really positive to meet.
Truck driver's like, here's exactly, and I'll quote, I ain't scared, I ain't scared.
Well, at least you know he's saying that from experience.
Oh, he was like, no.
So clinic wise, we're still in the summer model. When we get to the end of September, we'll switch back to the winter model, which means the walk-in clinic that's up here will go back into the primary care provider's office. We're still improving our process, checking in, phone calls, all of that. We're working on partnership, working with Steve and his team and making sure that we convert the patients over that to present to us that come, are patients assigned to us, and I'm gonna show you some analytics in the back. Making sure that if they're here, they get the one-time code to be seen, so we've had to do some adjustments, because of that, so we're re-educating everybody. And educating the patients too, so that's kind of one thing that is new since this meeting. Linda's been very active on the new build and all of her team of keeping this facility up and running, as we can read through here. Radiology volumes are here. We're hoping that the MRI number starts to go up because we're counting on that in this budget year. I'll pass it, so Ethan has his, update in here that you've read, and I'll come to you in a minute, Ethan. Analytics, so this is the month we, put in, the quarter we put in the analytics, as you can see, the first, pie chart, but if you can see the, charts below, the new patient still holds, right? So it's still holding its same
I
size.
thought that was interesting. I expected there to maybe be a shift.
Yeah.
For the
Yeah.
whole of June,
We
but
are
it
still
looks fairly,
putting people on.
fairly stable. Yeah.
So that's one thing to call out, then we have the referral volumes and all of that, but to kind of correlate with that. When you look at, and Rich, this is one thing that may be interest to you, when you look at the last zip code analysis in the 2024 to 2025. You can see 2024 in the Chester area was 465, and in 2025 is 828. Westwood had, a bump from 287 to 396. And then the Lake Almanor from 149 to 241. So we are capturing patients, but this report is good because you can kind of see where it's coming from. Now, this is unique patients. This has nothing to do with how many visits they saw and stuff like this, but it's another data.
This is evidencing that repatriation we talked about
Yeah.
a long time ago.
So that's that, and then, with that, Ethan, is there anything else you'd like to add maybe, the board, have an update?
Yeah, of course. So now that we're moving a little bit through the summer months and we're starting to get projects underway, one of the first ones that attract you guys is getting all the iPad best folks that are printing out every month. We'll be working with Deborah to figure out exactly what needs to go on those to make sure you have everything you need. And then once we receive them, it should be a fairly quick process to get them locked down and ready for you. That'll be in the coming months. So, Yeah.
So I was wondering, how many of us actually would need a device? Because, like, I mean, I have an iPad, an old one, but I have an iPad and then probably most of our board members may as well, so.
the side to that is if we're wanting to use it for things like policies and procedures, making sure that you have potentially confidential information. We would want to put our own security software on it, just to make sure that if it got in the wrong hands, we could lock it down, we could wipe it, do all those sorts of things. And so if you wanted to submit your personal device to that, you would be able to, however, we do have it in budget providing to you with a new one that came from Seneca that we would have control over. So there's some room for discussion, but we did budget to be open.
So instead of passing out binders, I will be passing out the tablets, is that correct?
Correct.
Or
Keep the tablet.
Yeah, that was instead we would.
Civ Assist.
Making sure everything was good online.
Okay,
Yeah, you have to find yourself.
So all the Civ Assist and all the packet information would be available online, so.
so they'd be able to go to their tablet at any time and look that up.
Yeah.
Okay.
Thank you. Sorry, you can keep going.
And as it develops, I may have more updates for you, but at this point in time, that is the plan. And then moving forward from there, Butterfly is going well. We've had our integration with them. We've gotten a lot of specs back from them. And so we are going to be having internal provider and clinical training with Butterflies for the meantime, starting with med staff. So that's early August. Then moving forward from there, we should be able to use it as a tool in the meantime until Cerner builds their, they need their full integration. Besides that, the other big project is with the new radiology group. That is in full swing. We are fully pushing forward with that. That is our deadline of no later than the end of this month. In the meantime, we've engaged with our third party MSP Apex to make sure that they get the virtual machines, the beacons built that are necessary for that. So from an engineering side, it is fully in development at this time. And besides that, everything that's on that sheet covers current projects.
How long will it take for the providers, for the ER docs or the outpatient clinic doctors to be trained on the Butterfly?
Well, we have 3 days that are scheduled where Dr. Nielsen, who's already familiar with it, will be running basically just a lab of this is how you do certain things. Does anyone want to see anything specific? And then from there, kind of the goal is training the trainer, almost where Dr. Nielsen is showing other providers and key staff. And then from there, as it comes up, we will have people around that know how to do these things that can then pass on that training.
We're
Yeah.
nursing staff as well.
Correct.
Yeah, and currently they're deployed, the two, one in the walk-in clinic, one in the ER. Some of the ER docs are very familiar, like Dr. Nielsen and Dr. Fernandez. And so they've been using them more as a stethoscope until the integration,
Okay.
everything happened.
Okay.
And then just to piggyback off of Ethan's two big projects, we have our smaller projects in the IT budget this year. We also have two big projects, if Judy was here, so we have an I2I project. That is, we're gonna slot between now and the end of the year, so we're getting out of summer. And that's a quality reporting tool, that will help us harvest the data out of Cerner and be able to use the power of that data that we have in there more easily, so we're not manually abstracting stuff. So that's one. And then after the holidays, before we get busy again, we're slotted, still a little more discovery, but for the Portal 2.0, which will give us more features than our current portal, like self-scheduling. There's some stuff in there. So those are the two big projects that we have within the budget. Now something slides in, we'll adjust, but we're trying to managing the IT resources too, and the organizational. We had, our meeting today with Ed from Cerner and Rick.
Yes.
Yeah, Rick Crow, which was, what was his title?
Our new services
Customer success
management,
manager.
customer
Yeah.
success manager.
Customer Success Manager. So basically, they explained it, Ed is like the sales guy of products. And this guy is our guy to help us refine Cerner. And so it was a very, I think, good meeting to get him up to speed. Yeah, there was a little bit of, heat on him, but on Cerner. But it was a good discussion with them and this is what he's hearing through the hospitals that he's at, so nothing was alarming. But there's a lot of positivity because now we have somebody that's more of a technical guy focused to help us improve.
That's great.
Yeah, our area, so that was today. We're gonna have quarterly meetings with them because as you get into the big systems like we are. Usually they have quarterly meetings with us and they have scorecards to show the efficiencies of how your build is going and all of that stuff. So that's what we've asked them to do and they agreed. And then in between those, the teams will have, like if it's Steve's team and Rev Cycle or Ethan's team, they'll have meetings in between to help move the system along. And then we can report up into that group, so a little more structure between us and Cerner, but I think it was a very positive.
So Brady, like, what are our top? I know you know that from off the top of your head, but what are our top, like, three focuses for this sort of?
Well, I would say Steve's, is probably a number one. And then there are, when it comes to the clinical side and Judy's side, we're getting pretty good at, seeing what's, with Bree and, the team, seeing what's working and what's not, and then, putting in a ticket and resolving it. But in Steve's arena, we're still dealing with build issues. We've made a lot of progress.
For the red cycle.
Yeah, for the red cycle, and Steve can talk about that more thoroughly, but I would say that's probably in our top. Ethan, do you agree with that, or?
I agree.
Yes.
And then just from the email, some of the analytics and the reporting
Yeah,
capabilities, it seems that our informaticist feels like, some of that wasn't built properly, that so we can access certain reports and this is a powerful tool. We should be able to dive deeply into this thing to figure out some of our business and our clinical analytics and she feels like it's broken. So I think that's another focal
yeah,
point.
that's another area, but definitely revenue cycle, from end to end of, from check-in to the bill going out is probably our big focus for this next fiscal year. And that's kind of what we talk to them about, because if we have new things that we're adding on, we want to make sure our current thing is efficient enough. So we're not just piling
Right.
on more negative,
Right,
so.
do they still have big freezes, like times when they just freeze, everything is frozen, all codes?
There are certain times we have a calendar right within of when they do those updates and.
That was a big hurdle for
Yeah.
us.
Yeah,
Now, I have a question around the internet, so, we're talking about PowerPoint fiber, but what does Seneca have now for Frontier, is it T2?
Dedicated gig.
Yeah, so currently we swapped over, I believe about a year ago, we have the gig through, it was much worse before that. Then we have a Starlink backup for when Frontier goes down.
So what would that Frontier speed we have currently, how that would compare to the fiber? Is it
It's
faster?
pretty comparable just because of how Frontier is out here. We can make the pipe bigger, but the water flowing through it doesn't change that much between. I know for residential, they've been doing a lot more fiber, but with the enterprise account that we have, we already have some better speeds coming through.
That's what I was thinking.
Yeah, it could make some change, but not super significantly.
And our backup is business class Starlink. So what, 250 megs per,
Yeah, somewhere around there.
so it will run our systems, not as fast, but in the weather system.
So one of the other, and I think Linda touched on it, but one of the other impacts to operations that we've had over this last month, we think it twice, where between Verizon and Frontier, one of their guys hit their fiber line and, it took out Verizon too. And what that means is we couldn't ambulance, I mean, no communication in or out or even calling amongst each other because we all had Verizon. So Ethan and Linda are working on getting, having some phones on Verizon and some phones on another carrier because that's happened, that's twice now. And so that we are not on the same, so when those go down, the departments will have their backup phones or however we do that. And so that way we can call the radiologist on the read, we can call the ambulance company. So that's one thing that kind of threw us a little bit because we didn't realize how connected they were.
Was that the
already.
July fourth week? Couple
Yeah,
days?
yeah, it was like.
Bad.
Even so, I have two phones and in my mind, when it was going on, I tried my other phone, they're both Verizon, so that doesn't. Trying to solve the problem with it. And that's it, if there's any questions.
Brady,
Yeah.
any other questions for Brady?
Thank you.
Thank you.
No, thank you. Okay, so then that brings us to Shannon's report.
Yeah. So we are actively recruiting for our medical staff coordinators and hiring. We do have some good candidates. We have 4 with direct medical staff experience.
Great.
They're not in the area. Of course, I'll be doing my initial interviews, early next week. So that's in progress. LVNs and CNAs are looking a lot better. We just had someone, since writing this, go from per diem to full time. We only have 1 CNA position open and 1 LVN. So that's really good progress.
Sorry to interrupt, how did our medical staff coordinator applicants find us?
Indeed.
Okay.
Yeah.
Okay, good.
Or, yeah. I haven't done any marketing for it. It's just,
Found it there. Okay.
Yeah.
Well, and we have, so Kathy Codner runs medical staff at Downland Menlo. And so,
did you confirm if she posted it?
yeah, I think she did.
Okay.
Yeah, so there's it's called HIMSS, no,
I don't remember.
it's an organization that runs medical
Dedicated,
staff
yeah.
dedicated for that. She's the president of Northern Chapter or something like that. So that she's been, posting it and stuff like that, so, which is good.
I'm still actively trying to get a physical therapist, and I'm having a lot of traction. I start, reaching out to the schools, see if there's job boards available. We did post it, originally on the American Physical Therapy Association job board, didn't get any traction there. So that's something we can revisit, but I'm gonna keep moving forward on that. MOU, we have our proposals all put together. We need to meet probably one more time on the economic proposals. Just to get those.
The union?
Yeah.
Okay.
Get those fine tuned, but we're gonna open it at early negotiation so we can get that underway, clean up the language. And then we're on 2 of the physician recruitment platforms. They're a little, I don't know, a little hard. A lot of people want to be in their area, so I get a lot of emails back, sorry, I want to stay in this state. So still working through that. Gonna try to really pinpoint people that want to be in California, smaller pool of people. We did get a direct email from a family medicine physician, Brady and I talking on Monday. He is interested in emergency room, so he's actively seeking a California license. His availability is very limited, so we'll have to kind of work through that. So
Where is he right now?
he's in Colorado. Yeah, his family, he grew up here, so he's trying to get back and family in the Bay Area, so
But he doesn't want to be in the outpatient clinic. He wants to be in the ER.
he wants to be in the ER.
Yeah.
So, and not very often.
Well, his availability right now, because he is currently working, like he's the primary care doctor where he's at, plus he's doing the ER shifts. in a locums realm. So what he wants to do is get his license and start doing it over here so he can get his toe back. And then eventually fully move back to the California.
Yeah, I think because he probably was saying that, about selling his condo, or kind of
Oh,
the
yeah.
hesitation on moving here full time. And maybe just testing it out for
Yeah,
the locum part that he's doing
yeah,
in New Mexico.
so the interest rates. Pretty high.
So
Good
that's,
luck with that.
that was good. So the statistics, we're really seeing like a 50% open rate on the emails that go out.
Which is pretty good, I think.
Yes, but I'm not getting a whole lot of any interest, just these are missing from So I'll continue to look, on those platforms. And we had a lot of new hires come on in July. We had, let's see, six new hires coming into this month. But everything else looking good. Any questions?
Any questions for him?
Is there like a large or like the biggest physician conference? That maybe we could attend and just try and sell?
There's, each, specialty has their own, organization that they go to. Just like family medicine, there's all these conferences. The schools, those are other good areas to post, positions if you're looking for new grads and stuff like that. They usually have job fairs and boards and stuff like that, but Doc said, those boards that we're on are like the LinkedIn for physicians. Those are the ones that we go to and look for, but this goes to show you the shortages that are only gonna get worse,
Yeah,
in the physician realm, so.
well, cause I know a lot of the nursing conferences that I would go to, there was always big recruiting.
Yeah,
At those conferences.
yeah,
And it was a good sell.
Yeah, I'm attending been invited to the California Medical Association Symposium, coming up a week or two, I can remember, in Sacramento. And there's probably 350 people going to this that are all physicians, and one of the reason one of the subjects is the advent of rural medicine again. So I think the burnout in the cities is starting to take real hold. Although they're talking about, what does it look like in rural America? So I'm gonna be there going, you wanna know? I'm on.
well,
It's in Sacramento, so it's familiar. With, a lot of people are familiar with this.
yeah,
So,
and we're getting like, this one, we have another doc that's looking for kind of full-time ER. In the shifts.
We're seeing that we're building a hospital.
Yeah, 8 shifts, so.
I think that will help. That does help. with
Yeah, so that complement is actually filling out quite nicely, and that will help us to kind of look at different models that we can do. We have, inpatient admitting thoughts, we had, walk-in, so we had, trauma in the last period of time that we weren't quite sure what we were gonna get. And it was very nice to have a ER physician in the walk-in clinic and one over there.
Walked over.
So that I could, at that time, I could, went over there and he said, I said, yeah, and this group, our primary care docs pivoted and took the walk-in.
Yep.
He was over here, we were ready to go as they were coming in.
Awesome.
Yeah, it was a multi-casualty.
So that was something like, oh, that's nice.
Yeah, so it was great to watch that.
Yeah,
Watch and say, hey, I'm a ER trained physician over the walk-in. Let's go over and see if I can lend a pair of hands, because we didn't know what we were getting.
yeah.
Right.
But I love to see that collaboration, that camaraderie.
Yeah, that
So,
worked.
okay, I'll cover the walk-in while you go over, because we didn't know really. It was unknown what we were gonna get.
Did we get head injuries?
Yeah.
Oh, that's nice.
One was auto lifted, but
Yeah,
yeah, they auto launched for one. But
so we can, with these, as we're building out our physician enterprise, we can look at different models and there's benefits, to those and discuss which ones
That's
work
great.
and that kind of stuff, so.
We never know what's gonna walk in the door at any
Yeah.
point in
Never.
time.
Yeah, it's great to have
You
that.
really don't. You really don't. And this also goes into the discussion around our model related to hospitalist activity and the revenue generation that we need to do in our inpatient and get more admissions. So we're going through a process of modeling and changing on ER flow, primary care, and walk-in, and soon to be coming to a theater near you is a discussion around modeling our hospitalist program or a rounding capability so that our ER doctors are pulled away from having to follow, because that's really where they don't wanna, that's where things stop.
I didn't know we had an ER position covering
Yeah.
outpatient.
Yeah, this summer, he's
Good.
went back and forth, depending on, he's done some ER shifts, done some.
Great,
And that's what he likes.
Love that.
great,
I was like,
great.
and some of these other docs that we've been talking to, they're of the same
thing.
mindset too.
Thank you. Any other questions for Jen?
Sorry.
It's okay.
Stole the thunder.
Thank you.
Thank you. Okay, so Chelsea, looks like you're up for your marketing and PR report. So, anything you want to highlight on this?
So just information stations we're pausing the two for the next 2 months, because in September, we're gonna be adding some new build events, and so we don't wanna oversaturate the market with all that. So we did take that information off and where it was, and we will let people know that when it comes in, that they're paused. But it looks like the last week of September, and we should have dates probably next week, that I will send out to all of you guys. That last week in September is gonna be pretty busy for us, as far as we're gonna be at town hall that week. We're also going to be most likely doing our, staff duty signing that week. And then we are also going to potentially be doing a see around the work event that week, so that's what we're looking at, is to fit it into everyone's schedule, that last week or so. So that's gonna be a pretty busy week, as soon as we finalize all the dates that is done, we out to the whole report and the managers, everybody. And let people know the official date. Other than that, we had a few press releases go out since, last month, we had some fun hires, and they've been being picked up by Action News Chico and the station Reno too, so that's good as well. We're getting lots of traction on Sean's videos, actually, that he's doing once a week, and once a week we're doing new build videos.
KQED area.
Yes, so here's.
A star.
No, I love that, and we're basically just doing these little updates that, update where we are we do it every Thursday.
Yep.
And then people can literally see the progress.
When do you post that?
We post those Friday mornings, I
That's right.
edit them, and they take a minute to edit, and so then
It's a lot of editing.
it's just we have to like improve this now, because we're out there on the construction site and everything and stuff like that, and then we have to do a little kind of.
Yeah, this morning was quite busy out there. Very busy out there.
Yeah, have you guys been going back recently after our meeting and been very.
Yeah, I'll walk you back there. Something else, man.
Yeah, walls go up there, siding.
I'll talk to you afterwards. Go ahead. Yeah, it's coming.
But, if you guys didn't know, we got second place overall for 4th of July. It was
Amazing.
good, I did get some people that were a little upset about the Grand Marshal banner being on our boat, because they felt like it wasn't
Sure,
a
that car.
special car, like it normally is. Now, last minute, the chamber came to us and said, we don't have a vehicle for the Grand Marshal banner, can we put it on your float, so we added it last minute for Malcolm Wall. Just so you guys know, if you get that complaint, we did the best we could at the last minute to make it look nice, but it was the last minute, we had to help them come up with a solution.
I thought it was.
Well, that's great, but some people were like, oh, it's all.
Should have had his own car, but no one volunteered.
Yeah, they couldn't find someone, and so it just ended up being with ours, so if you do guys get comments, that is why that happened. They have gotten into you, especially with his, memorial coming up this weekend, for celebrations like, coming up this weekend, it received more comments. So, that is that, other than that, band show went over great, we got a lot of good feedback from that. Thank you to the board members that were there, again, on the 31st is our next one. New monthly bills, updates, and newsletters are continuing to go out, we have a 90% rate on those.
And we have about 300 people that have signed up for them as of right now, so that's great. We're getting more and more. Social media is cruising right along, so we don't have a lot of like, negative things going on there right now, which is a positive. And, radio marketing, our student is going to record her ad this month, so, August 13th. And so this is, a junior at Chester High who won the competition for the ad, and so she's actually gonna go in and get to record it in studio, so that's a fun thing that we do with the students. Google Ads and geofencing ads, so, interesting stuff going on there. I shared some stats, so these stats that I shared are directly from targeted Google Ads for, visitors. That show like how many people like interacted with their ads, and then, like, for example, for the ads that were focused on clinic and provider, it showed, we have around 1,800 that actually interacted with the ad, or looked at the ad, but then of that, of those same people, we had 1,100 that actually called their clinic.
Yeah, I thought that was very.
So, isn't that interesting? Yeah, so that's, an interesting, data point. And then we had the ad that we have general to the healthcare district, we had 3,300 that actually interacted, almost 34, but 1,200 calls out of it. So it was interesting, so the, healthcare district ad is a very general one that just like, it shows healthcare district in general and shows clinic and hospital. Whereas the Lake Avenue Clinic one was more geared towards your clinic who are providers. So it just kind of shows the difference of where it is. So obviously we pay for interaction, so the one for just the district in general, excluded as well, because we didn't get as many, direct calls out of it.
Now, is it possible that someone is Googling us because they weren't contacting us in the first place, and the ad is served there, and then they go from there?
So that could be, the ad from there, is also, so they can see the ad the week before. And then that IP, still with that geofencing, that IP then is probably to press the call button a week later, it's still gonna collect them in that data. So so what it's doing is collecting the amount of people, the amount of attentions that saw the ad, and then the amount of attentions that actually called from on a number that is associated with our replacement. That's how that was. Other than that, I showed did some stats in there for that, which is great, because we went on with our providers. And our clinic rating is, that's the one that we're working on now, and that one is starting to go up as well. So that's just, all of our meetings, provider recruitment letter is at the printers. So this is a letter, the letter that's gonna go out to, more of the smaller groups of California area, a little bit of the Indiana area, we're using a little bit of those areas that Brady and Hannah and I talked about together and worked out where it's gonna go. So, that's should be going out in August. And, we'll see what kind of, response we get from that, and how that goes. So after the letter, we will then go to the postcard. And then with, Shanna's info on the providers, we also had, so for our providers page, 103 kids this month that actually used the page. And then of that, the average time spent on the page, 51 seconds. So we have 51 seconds to catch their interest.
Well, that's actually pretty decent.
That is actually decent, so 51 seconds. And then out of that is 77 that click further for more information.
So has that increased since I've been?
That has, so that is, this month is up 3.4%, last month it was up 9.something%. So we are tracking all that as well, so that has been increasing, it has gone up steadily, because our average, so if I go back 6 months, our average is 4 providers hit our provider engagement numbers, but it really, like, that's when we first launched it, so.
Yeah.
The emails are.
Yeah, they are.
somehow, you know, whether it's the digital ads we're doing, the email, whatever it is, somehow that is increasing, so there are more people seeing it. Now, producing viable applicants, I'm not sure of yet, because some of the ones that have come through.
But that can also, that's gonna increase your word of mouth too, as people are looking and they're getting information, they might talk to somebody else, so maybe they don't want to come here, but maybe you know somebody else who'd be interested.
Exactly, and that's what we're hoping for too with those letters, is even if the letter might, you know, the person who gets it might not be interested, they might go, oh, I've got a friend that is interested in getting out of the city or whatever it is, and
And the decision to move forward on anything like this takes months, you know, they have to put it all together in their head, and it takes a long time for them to reach out. But at least there's a tickler out there.
right.
So, and this in the month of August is recruiting season.
Time.
It starts.
Yeah.
The
So you
schools.
gotta get out there in August, because what happens is, you know,
January.
they're finishing school, you know, they're starting to check to see where they wanna go, and then if everything works out, you start getting hits probably October, site visits, all of that stuff, and then you land somebody. And those are for new recruits.
Yeah.
And then they take vacation, you know, June, July,
Holiday.
before they start, you know, real work, and then it goes.
They generally have made a decision by January, February.
Yeah.
They've already made a decision where they're gonna go.
Our targeted like digital ads for August for the provider recruitment, we're actually targeting junior and like senior students of the program, so.
Third-year residents.
Third year residents, I guess that's what we call them. So we're targeting those like end of the residency students for that, and we're targeting California right now. Yeah, so that's the targets for August. So partnership survey, worked with the group on this, the partnership survey, and, we got 89 responses for our 30 days of our survey out. Basically, you know, the survey was very directed by partnership as to what they wanted us to ask, and so we didn't deviate from those questions. What we did see out of it was a trend of people saying, I want you to ask me about this, because we did create an open-ended question at the end. So, we'll review those further and we'll see what people are asking for, but we will be sending out another survey that we have to do to basically qualify the survey in 6 months to check the metrics to see if we have an improvement on whatever area we pick for improvement. And so in that survey, we get to have a little more freedom because only one question has to be the partnership question. So in that survey, we'll incorporate some of these other questions that people,
What kinds of things?
so the partnership survey was very directed towards, they wanna know about access to care. So they wanna know, you know, did we offer them more than one way to make an appointment? Did we call them back within, you know, a certain amount of time? When they were here for their appointment, were they greeted by friendly, smiling staff? So those were the questions essentially that partnership wanted us, because this is all about the, patient experience. But in that, people were putting comments like, oh, I want you to ask me about, you know, the medical care I received, or I want you to ask me about. So we literally got comments within the open-ended question that said, and they weren't negative, but they were leaving us feedback on that, like, oh, this was great, this was fantastic, or this, or I want you to ask me about how, you know, how this worked. And so it was interesting because we did get some of those people that wanted some of those questions in there, and we got one that said, you know, I'd like a survey that is more about medical care versus the.
Is this tied into quality measure?
Yes.
Yeah, this,
And how's the survey distributed?
So the survey was distributed, so we worked with, Candace, and it was distributed through the portal. It was also emailed out to our patient list. And then it was also available for 30 days on site, so when they would check in, it was available there, and it was available in all of the providers' lobbies. So that, and then there was also a QR code to where they could scan that and they could fill it out online. So, 88 of them filled it out online. We had one person actually fill it out, like by hand.
and this is part of the next go around with partnership as they come on site. Like Judy's not here today, because she's at the partnership meeting, and that's, you have to have one representative. So when they do your survey, these are all checks that when they came couple months ago. These were things that they put on the board for us, and we took some of them to start that process, because I think it is September or October, we do our survey again.
Now, can we incentivize people to take the survey?
Not for the partnership.
Yeah.
No, it's actually.
Give them a stress
Oh, yeah,
ball
you
or
can.
something. You know, instead of a stress ball.
So the actually says in their stuff, yeah, is, and we can't target, like, make it available to everyone.
Okay, that's what I was wondering.
Yeah, but
I don't encourage people, because a lot of people aren't gonna do a survey unless they have some reason for it.
right, we didn't get a ton of participation, so it's roughly 8.9% is what we got out of the total people the survey was sent to.
Yeah.
That's how many people actually completed it.
Based on Brady's numbers for her clinic,
Right.
her patients.
Right, so it's, we didn't get necessarily a ton of participation, but we also, it wasn't bad feedback, it was good feedback. And the open-ended question did allow people to elaborate on things, which was nice. And the only issue that I saw was like, we had some comments about like, oh, nobody, you know, like, that would be nice to follow up on, but it was an anonymous survey. So you can't actually follow up on those questions, so that's something that we'll have to add to it, like if you want someone to contact you, put your information, yeah.
Of the 8%, how many were partnership?
We actually, the partnership
There's
is not
anonymous,
us
so-
to determine that,
Um,
but, probably not the majority of them, it just, you know. So, yeah. Okay, and then other than that, everything is just moving right along, history level for the main hospital, working with Marilyn to get our correct history for the area and all of that, and she's actually pulling in, like, family members of previous providers throughout the area, and she actually has given us a timeline of the providers from the start of when Pretorius was even considered Chester. So it is fun, so we're gathering a lot of fun information there. Any questions?
Any questions for Chelsea on that?
Last thing is the buy the beam, so we came up with a program that we agreed on with the contractors on how that's gonna work. So, essentially, instead of a large event for that, as a business or a person buys the beam, we're gonna schedule a time for them to come on where they're escorted on to go sign their beam. We'll take pictures, we'll do a video. We'll make it special, but it won't be a large event that disrupts. Okay. Foundation.
Yeah, foundation, that's good.
Okay. So, any questions regarding the report?
There's a question on the foundation report?
Okay.
Just, I think you've already covered some of the events that are gonna be coming up. And then I saw, PG&E.
PG&E
I wanted to shout out.
Yeah. PG&E is the commercial first partner, so the partners are people that just want to support the foundation and the district in general. And so then with the partners, we invite them to, you know, if they wanna come to the board meeting, or if they want to come to our events, we share all that information with them. And then with our partners, any information that they have that is beneficial to the community to know, that shadow box that is out in front of the clinic now, in this festival right here, is where we'll post partner information, so like if PG&E has a product, to make that off, or anything like that. So yeah, that's our first partner, we're working on getting some more. One of the big things with the foundation that we're working on right now is developing, our process for being able to accept stocks. So we do have a donor that wants to donate stocks, and so that's a new one for us, and so we're working through all of that with the donor right now, and that's kind of a tough process.
So once you have that nailed down, then somebody else has
Right,
it.
yes, and so once we have it down, then we take it out and see here's all that. And then, meeting with Pete tomorrow to go over, some quarterlies and some financials. And then hopefully by the next meeting, we'll kind of have an idea on, financials and next year with the foundation, and the foundation being able to cover some operating expenses as far as fourth quarter. That's the plan. That's good.
Any questions for Chelsea on the foundation?
Here.
Thank you. Okay, I think that brings us to Charlene. You have a little report for us, Charlene?
Yes, so for privacy, education, we are at 43% completion. And so all we're doing is, I just send a new list and, remind managers to let them know who has not completed their training. So, we're at 40% or 53% for that. As far as language services, it's going well. It's being used, and the only item that we identified is that education for staff to remember to see the interpreter guide. And then the next one is, we spent a lot of our time discussing risk assessment, so we did a roundtable and we discussed, because as part of our annual compliance responsibility, OIG expects us to conduct a thorough review of our organizational risk. And so we've done that, and we've identified 3 key items. We went through a list of them. But we've identified 3. One is regarding healthcare cybersecurity breaches. And the next one is accurate demographics. And then the third one, ensuring they'll have verbal authorization. So those are the things that have been identified, and so I've been working with Brady and Ethan to identify what's feasible and what can we measure for those areas. Okay, you're welcome.
Any questions for Charlene? Thank you. Thank you. Okay, I think that brings us then to Steve. Are you going to do some introductions?
Yeah.
Fabulous.
So I'm so pleased to introduce Kaylee Sonneville to you all as our new controller. This is our board, it's our board president, Jerry Nielsen. Danged if I know, well, I know you, Sherry, but what's your title, right?
Well, I think I'm the opposite of everything.
Okay. Sherry Throws, assistant to everything, and Sherry's a former Loomis County supervisor. Ken Crandall, who's secretary treasurer?
He's
Is what?
secretary.
Secretary.
Ken Crandall. He's been on our board for quite some time. And Shelley Stensler.
Stelzner, vice president.
Almost.
Gotta get, and we have Rich on board.
Oh, and of course, Rich is our treasurer. Rich Rydell is our treasurer. Kaylee comes to us. She's in Susanville now, which is great, so she's local, because Shannon was talking about it in our recruitment efforts, getting people to come out of the area. So great for herself, but we had somebody from Susanville. And Kaylee did though come from Nevada, from northern Nevada, worked with the state of Nevada and also worked in gaming, so her background in highly regulated, structured industries is gonna be really, really helpful, and she's an Excel whiz, so not only is that fabulous for finance and accounting, but Cerner, this is like a really great thing for, well, Cerner and our Paycom. One of the things that I've got Kaylee working on right away is starting to set up the templates and the analytical templates for our budget for this fiscal year, and starting with the labor, which of course is the biggest piece of our budget, and so we're really excited about. I think we're close to being able to roll something out to the managers and the other departments, so we're kind of excited. So Kaylee, if you want to say anything or? Yeah,
It's gonna be great.
you're welcome to stay, or you're welcome to keep listening in on the video, it's up to you.
All right, so Steve, are you gonna delve into the May report or?
Yeah, let's bust through May real quick, and then talk somewhat about the June report. So thank you to Jerry and Deborah for sorting through that board material stuff so we could get you the June report. That's the deadline, but exciting either way. Okay, so Ethan, can we go to one more? Yeah, that's the typical one more, the third page and rotate it, obviously. So the big thing that I wanted to talk about
about hearing, and can you, yeah, there we go, thank you. So the big thing I wanna talk about is the month of May, as you can see, was very similar to March, April, May. We had the progressive growth in total patient revenue. Again, we bought a pointer, but apparently the laser, you have to get, what is it, Ethan? It has to be green, not
It
red.
has to be specifically a Q
How's that for you?
work on this team.
You point
Yeah,
the
red
red
light.
laser at the screen and it
Yeah,
disappears.
disappears.
Do you
And then-
want to share the screen with the people online?
What did you say?
Oh.
Are you not seeing it, Rich?
No.
No, we don't have a laser today. I was just mentioning because Ken had asked previously if, when we go through a document like this, if we could get a laser pointer or something. And then we did, we got the red one and shoot it at the screen and it disappears.
Shopping for a green one now?
We were shopping for her green. And the arrow thing that Ethan's working, I tried to use it, oh boy. Anyway, so total patient revenue, we've seen the progression. You go back to February when it was 1.6 million, that was of course a 28-day month. And then we went to 1.9 million in total revenue, 2 million, 2 million 1. So we've had that nice progression of as we start to see people come back to the area, you know, as we go into spring and now into summer. And it's reflective also in our profitability, our bottom line. You know, where we've had the loss from operations right around $400,000 the last 3 months. The expenses have been very similar. We've done a pretty good job of managing our expenses. We still have a little issue with the negative variance on labor, which I really think now as we've gone into it a few more months, it really was a budgeting issue, and that's where we're talking about Kaylee, our new controller here, it's gonna be her big thing is to delve into our labor. So when we analyze our labor going into the current fiscal year, we're gonna break it down by FTE, we're gonna break it down by class of FTE. We're gonna break it down by average hourly wage and then break average hourly wage to how much overtime, how much double time. And so we can really see where if we're having variances, you know, why is that variance there? And then, of course, the big challenge we always have is to look at in the 24-hour departments, the nursing departments, and to some extent, the diagnostic departments, radiology lab. We have to, when someone's not there, we have to have somebody there, so. We're essentially paying for 2 people for 1 shift when someone's absent. Because we're paying that person that was there previously, that's there typically, plus the replacement. Now, theoretically, when we do the accounting on that, we're relieving the liability for that PTO when someone takes PTO. But at the same time, we're accruing new PTO, so it's a real interesting dynamic. The other thing is that sick time, we don't keep on the books because it's not a liability to Seneca when someone leaves, as opposed to paid time off, they take it with them when they go. So, when we have sick time, that's just a straight hit to the bottom line. There's no relieving a liability or anything like that. And there's also no predictability of the use of sick time, although with the way that the state structured the new sick time, I think it's pretty clear to us that it's gonna be more highly utilized in the past than, you know, we can't ask them, oh, were you really sick? Can you come in to be seen by a doctor? What, you know, just, we don't ask any questions, you call in sick, hello. And we're good to go. So it's gonna be an interesting process as we manage labor. But again, in this current fiscal year, we definitely had that variance. It's been pretty consistent. The other expenses have followed in line. With May as well, again, we see that go up to the very top, you see that we have very continued low utilization of our acute unit for both our bed surg unit, for both the inpatient acutes and for the swing patients. And then in turn, the ancillary services. So you probably say, quit telling us this, we get it, we got it. But you just can't overemphasize how significant this is to us. Yes, we're working on the outpatient side, we're having good results on the outpatient side, but I hope we can keep driving more. But we have to look for all sources of revenue where there's opportunity. So not a lot here and I'm kind of throwing this 13-month analysis at you for the month of May, and just to tell you it's very consistent with the prior months. If we're, for the record, we had a net income, but we had a loss from operations, $396,404 versus a budgeted loss of $308,000, so a negative variance of $88,000. Half of it was revenue, half of it was expenses. We did make up for it with a positive variance in the supplemental payment programs. And it's one of the reasons if you guys can recall, when we did the budget for 25-26, there was a drop in our one part of it, there was a drop in the supplemental payments. And that was that district hospital directed payment program where we received 12 months when we should have only received 6 months due to the circumstances I described then. So then going forward, we in 25-26, we're only gonna receive 6 versus 12. And so we saw the benefit of it in May. So again, there's just not a lot to May. I'll answer any questions or anything you guys saw when you reviewed the information or whatever you want to talk about as far as May.
Any questions for Steve on May? Rich, do you have anything to add? No? And then I will accept a motion to accept the May financial report. Thank you. Do I have a second? Second. Thank you. All in favor, Sherry? Aye. Shelley? Aye. Ken?
Right.
Rich?
Aye.
And I'll vote aye. All right, Steve, that moves us on to June.
Yeah, so again, thanks Jerry and Donna that for me being able to present this to you. It's been a long time of not having current financials, and it's bothered you, it's bothered me more, so I'm just thrilled to have current financials that I have no reason to believe that this won't be the trend going forward.
We're very happy to, Steve.
Okay, so did anybody find the one error in the June financials?
The revenues, I'm like, that doesn't make any sense.
Which one?
Well, let's see, gross patient revenue for the
Yeah.
month, yeah.
Yeah, you're warm?
Yeah.
Yeah, that was a positive variant.
Positive variance on
Geez,
this.
Yeah.
Times are tough enough, I don't have to,
Yeah.
actually Sean caught that one in the treasurer's meeting, so. Okay. Here, so. What I wanna talk about June, or start off the discussion and just, not belabor it or get into it too much. This is what we should look like. This is a great month. And I understand it's June. We're not gonna have the population and everything like this, but this just shows what we can be. And this was a really good month with again, the low inpatient. You just throw a smattering of acute revenue and swing revenue, and we're basically profitable. So we had a loss from operations of $222,000 versus a budgeted loss of $265,000. John, I just brought up that you found the error in the June financials with the positive variance or negative variance.
To show you, I actually look at them.
It's awesome. Ethan, can you just scroll down a tiny bit to where we can get, just where we can have that operating margin. So this is one thing, when I first came to Seneca and I saw that our operating margins were running 20+%, I said, oof, that's tough. But we do get the supplemental payments, and the supplemental payments, you can debate, all you want. But what the supplemental payments do is they basically make up the shortfall for the wholly inadequate payment we receive for Medi-Cal service patient services to Medi-Cal beneficiaries. So it's however you want to look at it, it's not just funny money. It may be funny money the way it's administered, but it's directed at the underpayment that we have on Medi-Cal. So regardless, it brings us whole and all that. But from an operation standpoint, that's why we pull out the supplemental payments, so we can really see, we run 20 to 30% loss. So for the month of June, we were at 12.8%. That's a manageable number. If you're at 12.8, next stop is break even. So
Getting close.
yeah, absolutely, without question. And so just that little bit of push from the inpatient side, plus all the things you're hearing from Brady and Sean and the efforts that Shanna and Chelsea are doing on the provider side, will continue to push on the outpatient side to generate more revenue there without a marketable increase in our expenses. We are close. So it just shows that little bit of revenue push really gets us closer to where we need to be. And, just,
So those swing patients, were they SNF patients that had acute needs? So we put them into swing beds?
let's see, I'm trying to think in June, that one I don't recall the specifics of that patient. Why they came to us as a swing.
I think it was might have been an unsafe discharge or somebody that was, end of life.
It was a very short stay though, I think, so, it's,
Okay.
I can do a better job of identifying the
Well, you get
nature of the swing.
If Judy were here, she would be able
Yeah,
to
yeah.
be more specified about what the
Yeah.
swing was exactly, but no, it wasn't waiting for SNF.
Okay.
Yeah, this to me just shows that all the effort that all of you guys are putting in is truly paying off.
We are,
I just want you guys to know how exciting that I
Yeah.
personally find this,
This-
exciting.
yes.
this, if we, again, the continued revenue boost on outpatient, really vibrant swing program and a good inpatient program, that
especially
that
care
12% is gonna be.
Especially if you're focused on the key pieces that were from Brady's
We're
report too.
gonna get to it.
Yeah.
By golly, by gosh.
Just, yeah.
Yeah.
That's the key, yeah.
Yeah, well, this is very, very exciting and very promising. I'm very, very excited.
Refreshing.
Yes.
Refreshing.
Yeah, it was, it goes back to when I first came here and we did the initial market study for the new hospital before we got smacked by COVID and all that. And it just showed that the demand was here in our area. You look at a community, say like those of you who've been around here a while, Sherry, probably from her supervisor days. Loyalton used to have a hospital. And that just did not have the population to sustain a hospital. And then when they closed their mill or whatever happened up there, that was all she wrote. But Chester, Lake Allenor, and now that we have a kind of a new relationship, if you will, with Westlake through partnership, that there's just there's a sustainable population here if we pull it in. And then when you bring in the secondary residents and all that, I've always said that this place is like upside down, because typically the rural hospitals do poorly in the summer and they do better in the winter because the viruses, the flus and everything like that. We do the kind of the opposite, we're strong in the summer when people are here and they're utilizing our facility, and then even a portion of the people that you know, have primary residence here, they leave in the winter, and so our population goes down and all those things, so. It's there, we just gotta get it and take care of it, serve it, and we can do this, and we have to do it, because in 2 years, you know, we look at our. Hey, Ethan, can you point your pointer down to row 42, way over to the right? So there's our net income, and so we're pre-audit, we're sitting at $4,589,000. So that's our profit, our accounting profit. But then we need to take out the intergovernmental transfers that we make to receive the supplemental payments. Because of the way it treats it for accounting, they don't run that through as an expense. So the net income we actually have presented here is a little, from a cash basis, if you will, is high. So we take out the 2.9, we netted $1.6 million, 1.68, whatever, 85 in 2025 pre-audit. But our debt service on the permanent financing of the new hospital is gonna be approximately that from a cash flow basis. So that's a little too tight for my liking, especially when you start looking at, I'm confident about that OVA is gonna not be a game changer, deal breaker, whatever it is for us, that we'll be able to manage it. But it's gonna eat away probably, certainly if nothing else, people fall off the Medi-Cal rolls. And so there will be less of that. It will shrink our supplemental programs because those will be smaller. We may not get some of the cuts that they're proposing. But, so that operation right there, you know, is right on our debt service number, so we've got 2 years to make that number bigger. So, but we can do it, we've shown we can do it, so.
Are we getting any hint from partnership as to what they anticipate?
As far as their,
Supplemental
Like the
payment
role.
reduction at all?
the good news is that what we're being told is some of the measures that are in the BBA, at least as they stand now. Is that they're not, some of the more negative aspects don't hit rate range, which is great. It's hard. So, and that's our biggest program. But again, what just the shrinkage of the program itself is going to, you know, affect us directly, but no, nobody's got that crystal ball just yet, so, I mean, they've thrown out numbers, but it's just not even.
They're all
worth
just,
it
they're all just
to-
modeling.
worth it
at this
to-
point.
Yeah,
They're modeling, trying to
worth
figure it out.
it to throw it out. I think the biggest thing is that we do have a period of time before, if everything stays the same, the more negative effect of it's not till 2027, 28, so before those hit. So we have time to get this right, so.
And I think I read that some of the programs, they're grandfathering in people that have already participate, but not allowing new participants, I think is what I saw also. So that was interesting.
Mhm.
I'm like, well, good thing we're already participating.
And I think that's where rate range is gonna be signed, the directed hospital payment, the DHDP programs, they wanna bring those down to Medicare payment levels, and right now, currently, what those programs are paying, or some of those programs are paying, exceed the Medicare. Essentially, what would Medicare pay for the same service? We exceed that amount in that area in some cases, and so they wanna try and bring that down. So.
Yeah, I'm just curious about the local demographics here. I haven't seen any numbers in quite a while. Population, full-time residents versus snowbirds, and we have breakdowns on that.
I don't have that.
What what are our full-time, what are all 3,700 total around the lake?
What's the number?
33 full-time. And there's a bit of a guess on what our summer population looks like in our swell, but it's upwards of regular 18,000 on a
keep
just pretty
wondering,
consistent basis.
Yeah, which direction that's going, I can see where snow might drive people out, but at the same time, you know, that. I know a lot of people are working full-time online and they're just anxious to get out of traffic.
We're actually the only growing district in Plymouth County, by my understanding. It's not extensive growth, but I think we're the only one that's not losing population. The county's losing population, but District 3, our catchment area is actually slightly growing. And it can be attributed to the remote workforce, which is also shifting back to some, you know, there's a lot of things being shifting in that area as well. What's that?
Back to the office.
Back to the office type stuff. But I think that Starlink completely opened up the opportunities, and I think it was taken advantage of.
Yeah.
So we're seeing a shift. We don't have any good data, it's just anecdotal stuff.
Well, depending on who you talk to, when Starlink went down.
Oh boy. It's like the whole world stopped.
Yeah.
I could just see Elon Musk twisting his mustache. Just,
Rapidly
I got
told me how
control
many
of what?
people here had switched over.
Oh, I was losing my mind.
Man, he's like.
I had to pick up a book. It's horrible.
Minnie was down.
Now that is.
Sorry, Steve.
Everything down, but.
You know, I look at the demographics from our payer mix. And our payer mix has just really been consistent for a long time. It's 70% Medicare, Medi-Cal with. There's that 70-55 is Medicare and 15 is Medi-Cal, that includes nursing home, so. Then about 20. Oh gosh, maybe 25% or so third party.
Commercial.
And then just 5% miscellaneous, including self-pay. We have really a very low, it's amazing, uninsured population. We'll see if people fall off our rolls, our Medi-Cal rolls, and slide into self-pay, but we have very low uninsured population currently.
Well, yeah, and the worrisome thing, obviously, the undocumented population is getting a lot of pressure to fall off the rolls, right? But there's also a lot more requirements for enrollment, which is now employment or volunteerism. I mean, there's a lot of pressure being put on people that to keep your Medi-Cal, you have to do X, Y, and Z. And that's where I think we'll start seeing some fall off.
Right, and there's 6-month redetermination, but that's on the expansion population.
Right.
So when they went to childless adults with Affordable Care Act.
Right.
Whenever it was. That population will have to do redetermination the
For
first
6 months.
And so we'll see how that affects us, but you know, you look at our, well, you can just see it right above, don't move it even. Just right above the top border there, you see that we convert, right now, our revenue converts at 70% of charges. It was a little high in June, but overall it's right at 70%. So that's a high percentage. Our third party insurance contracts pay extremely well. Medicare pays well right now, because of our lower volumes, certainly in the inpatient area. We did have our charge master consulting company. They've done a market price assessment. We think there's some opportunity for us to increase charges, and definitely in some specific areas. It's a very tricky exercise because we have limits about how much we can increase our charges through some of our insurance contracts, and they're really good, and we don't want to have the insurance companies open those up for renegotiation. if we trigger those clauses, so, but there's gonna be some room for us to increase, we can increase in certain areas, and maybe the overall increase falls within the guideline of the contractor, maybe they just don't care. You know, we have to report to them on an annual basis when we increase our charges. Our volume just maybe, as they say, budget us to, you know, the Anthems and United Healthcares and whoever of the world, so. But that's what we're looking at. Going back to June real quick, there was a variance on employee benefits. In the month of June, I put in the narrative. We've been working on reconciling everyone, all of our employees that are eligible for our 401(k) plan, which is the direct Seneca contribution that we make for our employees. We have a 403(b) voluntary program with up to 3% matching. The 401(k) is all Seneca provided, so we took us a while to get everything straight. We had to do a retroactive payment, so that was a one-time hit for the month. The repair and maintenance, we did some repairs on the cooling tower around the main hospital building. The supplies is typically generally related to our wound care program. But one thing just to talk about briefly is that as we go over to the far right, 3 columns, that's our year-to-date actual budget variance left to right. And so you can see our expenses, we're pretty well managed. The professional fees, I don't know, I'll have to talk to Sean what he's doing there with that, but actually the big piece of that was, we paid that outside company $186,000 to get us the additional benefit on our supplemental payment program. And then we did have some other professional fees above budget. Supplies, again, the big variance on supplies is related to the wound care program, but that had a direct relationship to revenue that we generated off of it. The remaining expenses are all pretty well in line with budget. I think we really do a good job with the management of our non-labor expenses. I was talking to Kaylee, the controller, and I said, you know, if we can nail down labor, you know, we really got it, because one, it's the biggest chunk of our expense category, and also all the departments seem to really do a good job with maintaining their budget to non-labor in relation to labor expenses. Be curious to see what happens with utilities and telephones. I mean, we have had such a challenge with both PG&E and Frontier getting invoicing for the services that we utilize from them, and so we still think there might be a bill lurking out there, but
It's so weird, they have no problem billing me.
I know, we have so many darn accounts because we have, you know, I don't know how many meters we've got here around the property, and you know, we've got Frontier for phone, we've got Frontier for internet, and so we'll see what happens there. But yeah, the rest of it was pretty well managed. So that's the report for June as of now. We're getting ready for the audit. The audit will start in September, and we'll have it, we're gonna really shoot to have it for the November board meeting. We have to submit the annual Medicare Medi-Cal cost report by November 30th, so that's the program there.
Right.
So questions about the month of June or the year to date or anything? And you can see there up at the top, the operating revenue fell pretty well in line with budget to actual. Obviously, we had negative variance on inpatient and a positive variance on outpatient, but that's it.
Great, thank you, Steve. Any other questions for Steve on June?
No.
Thank you.
Very, very good news. Okay, then
Yeah,
with that-
very, very positive, you know, I always get accused of being kind of.
Wet blanket?
Name it.
All right, I'll accept a motion to accept the June financial report.
Motion to accept the June financial report.
Okay, thank you. Do I have a second? Thank you. All in favor, Rich,
Aye.
Ken,
I,
Sherry,
I,
Shelley,
Aye.
and I'll vote aye. And that brings us into our updated cash flow report.
And nothing really here, because I've been dividing this a little on a current basis, and so, we should say June actual, I didn't have June done by the time I presented this to you also. That'll be June actual, or put it that, so there's really nothing new here. It's when we had the June board meeting, we already had a good idea about what June cash was gonna look like, so no real changes that I put in there, so. Just of note, Ethan, if you could scroll down to the very bottom. So. Right in the middle, total days cash on hand from the left. So we're looking at keep going.
Right there.
There we go. So this month was kind of an interesting one because, the big takeaway here is that that we presented this and we met with the USDA, we showed them that we're back, our cash is good. You know, of course, they remember what we went through last, fall, late fall, early winter. With line of credit and everything, so to have the 112, and it's not on this document, but as you recall from the budget presentation, that we're projecting a positive cash flow for fiscal 25-26. There are some things lurking out there. We have our contribution on the MRI partnership. We have potentially some contribution from operations for the support services building. So, but the thing that the USDA wanted to see is that if we're gonna do things like that, or if we need to do things like that, we do have the cash available, because that concerns them if, you know, that we're moving along with this project and we have these needs. Are we gonna be able to meet all our needs, continue to fund our interest sinking fund, monthly interest sinking fund, and all that, so that's kind of the takeaway here.
Thank you, Steve. Do you want us to vote on accepting this as
You know,
well?
it's under there, I don't know why we put this, maybe just because it was so significant previously.
I think that's
I
fine.
don't know if we can just put this under
With the
for
information.
discussion, or, yeah, just for report.
Okay.
Or if I should keep doing it, because I think it's a good.
And yes,
It's a good thing.
please
Yes.
do, especially getting us through our project.
Okay,
But yeah, if you want, for next time, we'll move it down to the informational section. And then if at any point you decide that, you know, there is something significant, and you want us to approve it, we can always move it back up.
you know, the only thing I wanted to bring up about that is that we had talked about renewing the line of credit, and that, I mentioned to you that the Western Alliance Bank's attorneys wanted 20 grand to do the line of credit. And I just, you know, we all just said, but now with OBBA, I think I'm gonna go back to Western Alliance with your blessing or whatever, that we would consider that if you would give us 3 years, and so that line of credit would ride us through OBBA, and I think it would be worth it if we did that, so if they can do that, then I'm okay. If they're gonna just do the little 3 months and pay us back thing or whatever.
There's too much unknown.
Yeah,
Right
it
now.
would be nice to have that in and then cover that period of time, so I think I will go back to that. And then we can see what their response is, and then we can take it to you guys.
Thank you, Steve. Yes, I think, Brad said, was it 5 years was the maximum that we could do? I can't remember what,
I thought it was 3.
was it 3? Maybe it was 3.
I thought it was 3, and I don't know if it had any relation to the project, but I think that BBK said the maximum amount of time we can do is 3, but I will look into that.
I think it
before.
said a municipality or
Yes.
something of our sort. There was a maximum amount. I don't think it was project related.
It was 20 grand.
They're just a process it,
And then BBK will probably
take a piece too.
chip in for a little bit. I can't see it's gonna be much, because they did do a lot of work on the first one, so I think it's just reviewing. Who knows? So anyway, okay, so it's under approved, so you guys, whatever you need to do, it's your call. Cash flow.
I think we can go ahead and keep it as informational and just
Okay.
move on. Thank you.
Okay, so this one here, I'm gonna just hit a couple high points. And of course, if you guys have, yeah, that's a great start. If you guys have any questions about what's in here or anything, we can talk about it, but Ethan, in that AR aging category there, the black, that section, yeah, okay, so these are our performance on the AR days, and I think this is just kind of where we really look at what's happening. One exception is right above that group there is our clean claims rate. Which, what that means again is that we'll get a claim ready to go, we'll send it to our billing clearinghouse. They'll scan it for all the codes and everything that they have set up to make sure that the claim looks good to them. And in the June, our clean claim rate jumped up to 75%.
Good.
From, they've been running in the 60s. One of the big ones is that we finally cleared up that taxonomy, well, not cleared up, but we still have a few providers that have that taxonomy code hitting for partnership. And these are, when you say clean claim rate, this just means we have to touch it again. This doesn't mean it's been denied, that's the denial rate. So it just means that there's something not set up and it would flow through if it was set up, but getting up to 75% is a great accomplishment.
Improvement, yeah.
I don't wanna go into this too much, but our clean claim rate within the clinic is 85% now. So for the month of June, so
That's really good.
it is, it speaks to two things. It speaks to that we're fixing things within the system and that I guess we know what we're doing or something. So, and it's reflective here, it does help in the ER days, and then second, well, I'll start with total AR, I mean, you look 90, 93, 90, 87, 80, so, and the big bugaboo there is that a big chunk of that AR is the self-pay stuff that we're still working on to create the means to where we can transfer AR to our hard collector, our bad debt section. It doesn't necessarily translate into any more money for Seneca or very little. The conversion rate on bad debt accounts is very low. But so from an accounting standpoint, it's not a big deal, but from the measurement of the effectiveness of our revenue cycle, it is a very big deal. So what we're looking at right now is that total insurance AR, which essentially pulls out the self-pay side. We're down to 50 days of AR versus a target of 45 for third party, so
Yeah.
really,
Great,
really
that's fantastic.
Really
Big.
good work.
big
Really good work,
accomplishment.
Yeah.
So, I just wanted to point a few of these things out because we have struggled and still that 80 is an ugly number, but we wanna see that 50. When I look at the dots versus the arrows, the dots are relationship to our hard target, the last number there in the presentation. And then the trend, the arrow is it trending positive? Is it trending negative? Sometimes up is good, sometimes down is good. And you can see every arrow, at least for the month of June, was green or neutral. So that was good.
Yeah, I really like that you guys added the trending column on here.
So what is the barrier to self-pay, going to collections?
The biggest barrier is that we still have some issues with the build, if you will, within the self-pay that we have had to stop and start with giving notices and the messages that go out, who's getting what message. We're on a prescribed I guess, a prescribed course where we have to do this, this, and this before we start the collection process. California is very rigorous about the collection process, but the biggest issue is that now, once we've worked through the majority of that and we're there, we have to now build the interface to our collection agency. The people that do our self-paced statements, that's all they do is they do statements. It's RevSpring, it's the people you get your statements from, the people I get my statements from. What happens at day 180 or whatever day it is, you have to start sending out all this information, like we have to send out a charity application, we have to send out specific letters. Good, it's actually kind of interesting, it's called a goodbye letter. And so it's like you're going to, you know, your account's going bye-bye. The bad place, I don't know, but it is literally referred to as the goodbye letter. And so RevSpring was not able to do this. So we talked to the company that we use for our bad debt, NBF, and they can do it. We've done all the work and now we just need to create the final interface to them.
Okay.
And that's really a matter of the time because we've got essentially one person working on doing this for us internally.
Okay.
So we're quite close there. And that's it. And the interesting thing about it is if you go into this report that's done by R1, and there's a report that shows the collections by current pay source. You know, so say Medicare, Medi-Cal, blah, blah, blah. You can see the self-pay, there's a line there. And we looked at it previously, we could see we're really starting to get some collections there. And so people are paying their bills. So it's not like this is just, nobody's paying their bills or anything like that. We're getting pretty significant collection on patient responsibility. It's just that in a normal cycle of this, it would go to bad debt, it would come off our books.
Right.
So just all of the self-pay AR since we went live on Cerner is sitting in our active AR. So, but people are responding to our statements. They're paying it, yes, maybe they're making some inquiries from time to time, but they're accepting our statements as they owe that money, so that's always the.
Yeah.
You know, that's the proof, is if someone will pay their bill, I mean, some people just don't pay if it comes in, but. You know, there's definitely people that look at it, so. So that's kind of the self-pay story. I'd like to give you a hard timeline, I'm thinking this year, this calendar year. That we get that rolling, and that'll be a whole interesting fun thing. So, one thing that'll be interesting though is that California's gone to where they're trying to relieve. And I get confused because somewhere it says that it's the law and somewhere it says it's not the law. That you can't put medical debt on people's credit reports anymore, so. And so that was one of our biggest things, is that somebody would say, you know, they wanna go buy a car, buy a house, whatever it is, and they've got it on their credit report and say, okay, I'll pay it to get it off my credit report or whatever. So I don't know what the incentive is gonna be for people.
Yeah.
To pay better and bad debt. But we'll see. So, yeah, last thing real quick about this slide, well, actually two things, is that the insurance greater than 90 days, just as with the total AR days, it's over the target, 45 versus 30%. Just again, because of self-pay, as you can see, I don't even know where we get self-pay over 90 days is 5%. We're probably gonna have to look at that, because we can't turn people till a minimum of 180 days, so that's probably not a good number once we get to it, but anyway, doesn't matter right now, but the insurance greater than 90 days, we're at 23.7% versus 25%. So that's a great green dot. So important. Denial rate is comfortably settling in at about just under 10%. I know we have a target of 5%, and we'll get there. But just having it down in single digits and having it consistent for the last 3 months is important because. You know, unlike the clean claim rate, that means that the payer is rejecting it for some reason. And then that's a bigger problem. One, it could be a problem with the claim, two, it could be a payer be difficult, and therefore it becomes upon us to. R1 that is, to manage that and make sure they follow up and challenge those denials as appropriate. So. We saw the denial rate for July and I'm asking them to verify it because it really went down in July and that was really an exciting thing for us. So. That's it for R1. Any questions about R1?
I'm not on R1, Steve, but did you want to mention, we were talking about writing off?
Yes.
I bet.
Okay, so. All right, you don't see it in the R1 report because they're just looking at the Cerner AR and quite frankly. In this R1 report is just hospital and clinic at the very end of their slide is one slide for long-term care, which is done through the AmeriCare system. We still have about $1 million of AR that's just sat on our books from, my gosh, some of it we think is still from 2 legacy systems ago, before Evident. And we've exhausted all collection efforts on those. And so we'll be writing that off through the year end, this fiscal year end process. And it is gonna be $1 million coming off the book, and you'll see it in both the AR that's presented in the balance sheet here in my financial presentation and my AR days calculation. And it'll have no effect on our financials because it's been fully reserved for quite some time now. So now my presentation of AR days will line up more accurately with R1. But R1 still doesn't, this is just hospital and clinic and everyone's done such a great job on the long-term care that our AR days on long-term care are around 30-35 days, so it's a smaller amount of our AR, so it would move this number down a little bit, but so now it'll be a little more apples to apples. And so any concerns or questions about the old
Like it makes sense.
legacy AR? Yeah, thanks, Jerry. So Judy. Okay. So there's some more questions about R1. Real fast, gave you our latest update on Cerner and Brady talked about our call this morning with our customer success manager and the model that Cerner Oracle is going to. One add to that is in all of discussion we had with them is we floated the idea or the discussion or the idea came up about Cerner sending out a team of people to come here and work with us and try and solve some of our build issues. And I think we're gonna pursue that vigorously.
What is the cost for that?
Well, I think that what we're talking about, right,
TBD.
now, they could send out if they could send out the people on their dime, we'd pay their out of pockets, so. We'll see if that flies.
Okay.
But if they're really serious, like they said, you know, they set us up, they teed it up for us, they said. Hey, we want you to be happy and we want you to one day be an example of what Cerner can do for a small rural hospital. I said, hey.
We would love that
Make it work.
too.
Yeah. Make it work for
I said, we're not that far off. So bring it on, let's do it and we'll get it, so. You know, we'll just see how this proceeds, but the idea of having the quarterly meetings plus having specific things for like revenue cycle, patient accounting and IT, I think is a fabulous idea, so. Last thing is the USDA financing report. So, I did do it through July, but we did not get approval for outlay request 10, which we just did and paid. It's not in, did I get it in there? Can you rotate that real fast? Even go to the Geo bond page. Keep going, go. More, or 2 more. 3 more. Okay, go to the bottom. Okay, we did, so I did get it in there, we just paid 10, so yeah, I got that in there. And, we submitted 11, 10 was for the month of April. And 11 is for the, month of May, and that just went in last Friday. Right now, we're only submitting, and Donna will talk about this in her part, we're only submitting, the pay requests are for the general contractor. Or Monley Hammond's piece of it, the soft costs, the architects, the inspectors, Donna. Right now are being held up, so USDA can do some contract and change order reviews associated with those areas.
And we've got that meeting scheduled in Davis, next Friday on the 8th. We're getting face to face with them, and we're gonna work through all this. The soft costs, so that we can get these things moved down the path.
Now, when it comes to, and we're gonna get to here, we're not here yet, the stairs quote and the striker quote, now I saw, I think it was the striker one, they want 50% of part of the cost up front. Is that gonna get submitted through the pay app for reimbursement? How are we gonna,
Part of the,
how are we gonna
Be part
fund
of
that?
pay
I know we're not there yet, but it kind of ties in with this.
We're paying we're paying some of the money up front. Okay,
No, we,
Did I misread it?
no, there was a.
it's right there.
Sorry, guys, I'm jumping ahead.
that's all right.
No, I think, no, I don't think we have to determine, like, we're so early, so do we wanna go into striker?
I think that's okay if we kind of dovetail.
I'm done, so, and that's just information only, so yeah.
Okay, thank you, Steve,
Mhm.
but don't go anywhere. We're talking about money. Yeah, so let's go ahead and go on to that item number 9, the striker equipment quote.
Donna, do you want me to?
Sure.
Who was supposed, okay.
Yeah, so this, sorry, I'm just gonna say, it's on the very last page that I was looking at. Where it says deposit required immediately, $335,000. Right, exactly, that's what I'm asking about.
Well, okay, so, and I'll talk to Striker, so this was to go back and then I'll get to that question.
Okay.
So, year and a half ago, one of the very first board meetings, Striker came and they were trying to put our feet to the fire of, getting, their PO and all of that stuff. And at the time, we didn't have even a general contractor, that's when we were in the rebuild process to hold pricing. So the board at that time decided that we couldn't do this because we didn't have a general contractor. Now, we would fight that battle, in the future when it was time to bring that. So, fast forward to the change request. So Striker is these pieces of equipment that are, within the ER lights, OR seats. They, quoted us again. We went back to the original quote, even though we didn't do anything with it. And, we used to carry it in a stick. And so we've got them to, I think, and Donna, you can correct me, a delta of about 15,000. With all of the products. Part of that is also looking at the Striker gurney line, which in the quote, we did Hillrom. So that's a different project, but that's the carrot part of it. And so in here, they know, cause they went to their superiors, did the whole process, supposedly. And, they came back and gave us a discount on the light, discounts on the units, and also we looked at what they were quoting us, and some of the things that they're quoting us were like the Cadillac, and we would never use them. So we've got this, this pricing, which is, and this is where process, we have to, within the change order, we've, approved all of these, you know, items within the construction and the equipment. But this is the medical device category, and all the medical devices will come to the board unless, as Donna's gonna explain, that you do it from a budget standpoint and then bring them to, the board as awareness. Because some of these things have time. When they give you a discount, they, you know, there's a time, and so we don't want to lose the negotiated price, because at this point in the construction, they need their drawings, you know, all of that kind of stuff as we go. So, I will revisit the terms of it and making sure it's not a deposit, because when we talked about it, it was, not a deposit, because they still have to give us the drawings, we don't have a delivery date. And usually, it's, once you get the delivery date, that's when you, pay the majority of it. And so I
We
can,
had talked about,
yeah.
it, but I was surprised.
They
and all that.
yeah, so I
They
can,
might request a PO, but no exchange till
yeah.
a later date.
So I'll review that with Al and stuff, but just a shout out to Stryker. They did step up. So, I mean, really, they had us and we didn't make a decision, prices change and stuff like that, but both, Al and Jake, his boss, really went to, and that's a pretty acceptable range, a year and a half.
Yeah. No, I think you guys did a great job.
Yeah, later, so.
And what do you want from us for this then?
Donna, what is the action required?
So until we get the procurement lists updated, which I spoke with Stryker further today about, getting those at the latest for next board meeting. But until we have that to be able to say, okay, this is our total number for equipment. Can we get board approval to purchase within these, parameters? Until we get that, we're asking for approval to, for the purchase order for this one, outside of that overall picture.
And it's really the delta.
It's 15.
Between what we approved in the change order to the medical device.
Yeah, but we also don't want the deposit required immediately, component either, so, so. That part you can work out separately.
Yeah.
So you just need us to say it's fine to go ahead with a $15,000 overage from what the original.
Issue the PO.
From
And
your-
know that this is not coming from project contingency that we've been tracking through contingency usage requests. This is different. Because when Entroba put together their budget, that resulted in those dollars within our overall project budget, there is a contingency that they have within their numbers, because again, they're dealing with price variations from that time till now, and dealing with just, you know, from budget to actual quote, just making sure that they're having contingencies to cover any of those deltas. So there's dollars within Entroba's cost estimate that is that this 15,000 would come from. So as they're managing to that overall number that we will be getting you again for August at the latest. The overall list will be August, and we'll be able to track that contingency separately. But that this 15,000 would come out of that.
Thank you for clarifying, Donna. Anyone have any questions, comments on this?
No, I would move approval of the increase of the 15.
Great, thank you. Do I have a second?
So,
Thank you. All in favor? Shelley?
Aye.
Sherry?
I,
Ken?
okay,
Rich?
All right.
And I'll vote aye. Thank you for working on getting that so closely back in line too.
Yeah, that was all, I want to give props to Brady and Donna, that was a lot.
Yeah, yeah, I
A
can
lot of
only
negotiating.
imagine. No kidding. So thank you. Okay, so that brings us then to item number 10, Newport Access Hospital, skilled nursing facilities, stairs equipment, quote, approval to issue PO upon concurrence with USDA. Okay, so I should also say that the other one is a concurrence with USDA too. Okay, so now you have the stairs item in front of us, Donna. So let's see.
Okay, Brady, do you wanna, do you want me to
Yeah.
start on this one, or you want me to, or do you wanna start on
Well,
this one?
Yeah, I don't think this is ready for action yet.
Okay,
But just let's do a little overview of what the products are. And, so
so,
in the OR area, there's this central sterile area. And in the central sterile area where we process all the instruments for surgery and for the clinic and stuff like that, there are many medical, pieces of equipment that Steris is going to supply. Scrub sinks, things to clean, endoscopes, sterilizers to sterilize the, medical equipment, different kinds of sterilizers. This one is a larger sterilizer. We have a sterilizer similar to what we have today, and then we have a cold sterilizer that will sterilize power equipment and certain types of scopes. So, we had a change order because of the sterilizer. And we brought it to the board. I think I had a similar discussion. How they did the analytics to determine what sterilizer we need in the future based on the feasibility study of the procedures we were gonna do was basically, they saw what we had and doubled it. Well, what we have is a small unit that, can sterilize little packs and maybe 2 trays at one sterilization cycle. And the sterilization cycle runs probably about 2 hours and has to get to a certain temperature and exposure for a certain period of time and cool and all that. So when you're talking about this future hospital and this OR that can do joints and stuff like that, those trays are 5 trays, 6 trays, they come in, all of that. So Judy and I worked on this with Donna. We kind of went through all the different, as we're kind of going back to the choices that everybody did. And that was one glaring theme that popped out. So Linda dug into it. We analyzed all the sterilizers that they picked, making sure that the products that we're gonna have for these surgical procedures can be sterilized by everything. And the one thing that was apparent that we had to change was making sure that we didn't have 2 small sterilizers, which redundancy is good. But we had 1 small and 1 slightly larger sterilizer, so we could do the bigger trays and stuff, and that you don't have to run your central sterile 24/7. So that's the other thing is, if you had, our hours of operations, if we had one that the load cycle, you could do 1 or 2 in the big one. The cycle amount per cycle is cheaper in the bigger one because you're doing 1 process that can handle 15 versus, 2 to 3 in the other one. So it was determined after even with the company, because we started, now this company, it's all new people, like, how did you guys get here? And so it was determined and we brought forth the change order because it is slightly different structurally to put this one in. And that's what this is. Now, what Stephen has done, Stephen Stoops. Yeah, Stephen Stoops. Has done is he's looked at all of this because in that same time, we were with Premier, the initial quotes, now we're over at Vizient. So he's looked at all of this stuff
and repriced it in the new structure and activated some, tell me if I'm wrong, Steve, but activated some mechanisms within Vizient to get better pricing. And when he did that, this unit here is considerably less than what Steris quoted us new. And then the smaller unit, or no, this one was slightly above, but the smaller unit is slightly above. So we've asked Shell, who's the Introvo person, to look at this deck of equipment in the new pricing and to see what the delta is, which would be the ask, just like Stryker. We haven't got the math on that yet to determine exactly what are we over, but that's kind of the background. And Donna, did I miss anything?
No, the only thing I would add is that the amount that you guys approved previously and just trying to explain why we asked for that on this and why we aren't asking for it on Steris or on Stryker is because it's a bigger number. It was a bigger number. So, you know, we had previously asked for 80,000 from contingency to cover this overage. And so we're just doing the math, like Brady said, to make sure that where we stand in comparison to that, and making sure that we're reporting accurately this, where we're landing, having already asked for that 80,000 for the scope.
Yeah, and so what I'll do is, and similar to what I've done with Stryker, is we'll go through this with a critical eye and making sure, because this covers, as you can see, the different, it's got scrub sinks, it's got shipping, it's got all of that stuff. To see if we can, wherever we stand right now, if we can get that smaller, this would fall in the medical device, you know, or medical equipment, which has a contingency in there. But we don't necessarily want to use it unless we have to. So that's kind of the work ahead, and we'll have that to you for the next board meeting.
So Brita, I meant to ask you earlier about Durham. Where are we with Durham? Because they're certainly gonna use some supplies if we get Durham in.
You mean getting that service?
That provider, yeah, we're gonna share with podiatry.
Podiatry.
It was podiatry.
On August 8th, we have a new recruit coming in, they have another recruit. And so we'll be doing the tour and on that next Friday. And so the idea is they would use them 3 days, we would have them a day. And within that day, it would be a clinic day and surgery piece, but we have to figure out.
Vertically,
Yeah,
they decided to go somewhere else.
yeah, figure that out, so.
Okay.
But yeah, we do still have activities for,
Okay.
and then when you're looking at all of this stuff, because. When you step into that arena, you have pins, wires, drivers, power equipment that to do all that stuff, so that's a little kind of getting in the orthopedic. You know, equipment realm, which. I went through everything we have, and it's in a drawer, and we actually have some stuff, so we have frag. Like screws, plates, we have some of that stuff, we have pins and wires, we have the wire drivers. You know, I haven't turned it on or anything, but we could. You know, go through that stuff that we have for the podiatrist.
Like funding activities or something.
Yeah, JJ said at one time we had somebody and that person was pretty busy, so I know we have a lot of the stuff.
Yeah.
It just, we have to make sure we get it all squared out.
Right. Okay. Thank you.
Thank you. And so for this, we're just holding tight on for now.
Correct. Correct, Donna?
Yes, correct.
Yes, okay.
Thank you. Appreciate that, and thank you for explaining that. That really helps.
Yeah.
That helps us follow. Okay, so then I think with that, that brings us to item number 11. New Critical Access Hospital Skilled Nursing Facility General Update. So with that.
Alrighty. Do you want me to go ahead and go through these, or do you want to ask questions?
Why don't you just highlight any changes
Okay,
from last week, if you don't mind?
you got it. Okay, so no changes from last report on the schedule. We're still working with Monley Hamlin on the schedule there. Contingency usage requests, as was referenced previously, all of these have been I don't know if it's too strong of a word to say revoked as far as USDA, but they are re-evaluating them. The only ones I have very few that are that they're saying is officially approved. We have change order 1 and 2 for Monley Hamlin officially approved, and we have one of the items from contingency usage request 3 officially approved for Costco. And they are really diving into the change order requests for HDA and Entroba, and they're really like tooth comb. And so, like Sean said, we have this meeting set up for next Friday. We feel like it's 100% supportable. It's just going through just sitting down, going through the documentation, explaining the details around the fact that the complications around going from design build to design bid build, and the just going through it with them line by line, so to share with them all the documentation to put their minds at ease for everything that is shown within these contingency usage requests. The last one is this contingency usage request 7, which is a separate agenda item. So we'll talk about that in a bit. Any questions on that? Okay. Okay, moving on then. Design is complete. I am proposing that we have all permits. Electrical engineer of record is fully on board, so I'm proposing that I remove this from our tracking for future reports to the board, and then just move it to right now. The only reason I'd be keeping permit open is because we've got a couple things going on there, but the good news is that all of the HCI permits have been received. So we're going through and we're doing some change documentation now that we have increment 3 approval. There are some things that we were holding to get approval, things such as looking at changing some of the faucets from from paddle handles to battery operated, so things like that we couldn't deal with while HRI was still doing their increment 3 review. And so some things are coming down the pipe there, but it's not something that I would recommend tracking on an individual basis here. County approvals, we're getting the softening of the turn from Reynolds Road to the facility. That's in Plumas County review right now, and we're in communication. We remain in communications with Peninsula Fire to get all their sign-offs, but don't anticipate any issue there. Medical equipment planning, we've talked about pretty extensively here, but again, looking to get the overall lists inclusive of the lab to you guys in August. So all that is being worked on diligently by Entroba. More to come on that. Construction, as you all have seen, very exciting. All the vertical movement, getting steel up. We had our last slab pour today, And we'll continue to go vertical with the remainder of the steel, followed by the metal decking and roof curbs, and then ultimately roofing, still aiming to get dried in for this year so that we can continue work through the winter.
Donna, can you, somebody just elaborate a little bit on what dry in means? I understand it's a roof and walls, but I mean, is it people gonna be freezing inside the building, or is it, like, what, how far does dry in go, I guess is my question.
I'll take, yeah. Good. So the project manager or the super does have a plan for warming the building, you know, with portables and stuff like that. So they're already looking at warming it. It will be dry. It'll be cold,
Yeah.
but he does have a plan for warming
Okay,
so that they can continue. Donnie, you want to add anything to that?
Well, and I would challenge too that we have our rooftop units that are able to be dropped, as not dropped, but technical term dropped, put on the roof. So that ultimately, not that those have to be in place, and they're not going to be ducted and all that, but that's another option that can be explored with potential use of those as well.
Okay, well, thank you. That's just a curiosity question on my part.
Good question. I've been wondering the same thing about heating it.
Yeah.
Yeah.
Yeah, no, they have to have some way, like Sean said. So, alrighty, moving on, USDA financing, as Steve indicated, the outlay request was submitted for May. We had a meeting with USDA on the 25th, discussing processes and associated paperwork for these approvals. 11 and 12 will just be continue to be just the contractor, and soft costs are not being approved until we have this meeting that was referenced for next Friday, but not being approved by USDA until after that for sure, as we go through the details of each contract and each change order.
Then I also done, I'm just gonna interrupt real quick, USDA folks did indicate that they think they'll be coming out approximately once a month. I don't know if they're gonna do it in the winter time too, but I thought that when they come next, I was hoping to keep inviting different board members to attend with me, because I think it's helpful for everybody, so just so you know. Go ahead, Donna, thank you.
Nope, I think that's it. So,
Great.
yeah, I think that's it. All to report.
We're hoping to really make some headway on Friday. We're just gonna get down to the nitty gritty about all these changes. It's me and Donna, and we're gonna be in their office, so we're hoping to make some real headway. Get them to understand so we can clear these soft costs.
Great, thank you, Donna.
Thank you, Donna. You're awesome.
Thank you.
Okay, so I guess that brings us then to item number 12. New Critical Access Hospital Skilled Nursing Facility, request 007 for contingency usage upon concurrence with USDA.
And this one is not proposed to have action, only because we are indicating that this is for information only to the board, because it's all of the items are within that first tier of the resolution 452 that allowed for anything under 25,000 to be approved by unanimous decision between Sean and Steve. So that's what I'm referencing in that first paragraph there. And so so this is for, again, for board information only. And the contingency, I'm so sorry, I'm noticing that I think that there was another line item here that I did as a revision, and I must have provided the non-revised version for the board. I'm so sorry. There was a number 27 that was for 2,000, falls into the same category. that it is, for, the surveyor to be able to do the paperwork for the easements for PG&E. So all these, inclusive of that last one, is within Sean and Steve's approval, and then they do need to go to USDA for approval. So then if you
Any
scroll,
questions on the process? Board members? Yeah. Go ahead, Dawn.
I'm sorry, if you scroll down, you can see that, where that puts the, contingency at the end of the day. You want to deduct another 2,000 from that 1.2 million, so 226 is what remains. And for the owner's contingency and construction is that 5,326,523.
I guess my question that I have after you said that, Donna, is why structural steel changes are coming out of owners rather than construction contingency?
Donna, why were the structural steel coming out of owners instead of construction?
It says construction.
Structural. steel
They're
number
not, they're
two,
coming out of
26.
construction. The contingency types, is the construction.
Okay, so then the 2,000 additional comes off of the 5.3 million. I must have misheard you, I'm sorry.
I'm sorry, so the 2,000 is the only one that's coming out of owner's
Right.
contingency. All these are coming out of construction.
It's for the easements
That
consulting.
makes sense, thank you, I missed
Sorry.
that part of it.
Thank you.
Thank
Yeah,
you.
good catch.
Okay, great, any other questions, comments on this? Okay, thank you, Donna.
Okay, thank you.
So that moves us to item number 13, policies and procedures. Board members have any questions, comments, changes? Okay, then I will take a motion to approve as listed.
I am motion to approve.
Thank you. Thank you. All in favor, Shelley?
Aye.
Larry? Ken?
Right,
Rich?
Aye.
I will vote aye, and that takes us to our medical staff report. For approval requested by Dr. Dana Ware, Chief of Staff, for the appointments that were already approved at the med exec staff meeting on July 8th. Do I have a motion to approve?
I'll move.
Thank you. Do I have a second? Thank you. All in favor, Rich?
Aye.
Tim?
Right,
Shelley? Aye. Jerry? Aye. And Harry vote aye.
Just a note for future, in August, there's going to be a lot, as we transition the radiology group, there will be a lot, just so we let you know, for 60 days. So for next time. Thanks.
Get a nice long list.
Long.
So we don't pass that one.
Yeah, don't pass out when you see this.
With that, we move into closed session. So I need a few minutes.
Yeah, we're still learning more there.
All right, we are back in session. Oh, that's not really in there. Let's see. All right, we are back in open session. There were no reportable actions taken during closed session. Future board meeting agenda topics, and I'm striking off number 1 because I researched that and that's an error. We actually did approve our finance investment policy a while back and I just somehow neglected to take it off of there, so. Position contract negotiation, authority of the CEO at some point, if you wanna bring that back.
What?
It was the position contract negotiation, execution, termination, and administration authority of the CEO. We've had it on future board meeting topics for a while, so just
Okay.
so you know. Board planning session, any other topics you guys wanna add? No, funny. Yeah, our next regular board meeting is going to be Thursday, August 28th at 2 p.m. here in the conference room. And our meeting is adjourned. Thank you.
Thank you. No.